Hello, welcome back to Oral Surgery Journal Club. Today we have an interesting article to talk about. This article comes from the 2016 JOMS and it concerns OSA, or obstructive sleep apnea. This article looks at how MMA, or maxillomandibular advancement, which is essentially orthognathic surgery where you advance both the maxilla and the mandible, and how that is used to treat OSA. This article was written by Dr. Reginald Goodday, who is the chair of oral surgery at Dalhousie. And from what I understand, that's considered a very strong program up in Canada. And Dr. Goodday has written on OSA. He's written a chapter and a bunch of articles on this topic. All right, so it's a retrospective study from 1996 to 2014, all the patients that were treated in his institution with MMA for OSA. All right, some background information about OSA before we get into the study itself. So it's a fairly common sleep disorder. It affects approximately 2% of women and 4% of men. And there's other studies that suggest it's probably underdiagnosed and it may affect far more than just those numbers. We know from longitudinal studies that OSA is correlated to hypertension, diabetes, cardiovascular events, strokes, deaths. So it is a serious public health concern, and it affects daytime sleepiness or somnolence by not being able to sleep at night, obviously, and that could impact workplace accidents as well as motor vehicle accidents. In terms of diagnosing OSA, so the gold standard is polysomnography, which means that you go to sleep and you have a sleep study and they attach a bunch of monitors to you, including EEGs, EMGs, EKGs, pulse oxes, respiratory effort, all sorts of monitors, and then while you sleep they analyze and they're looking for episodes of apnea and hypopnea. And so here's the classic definitions. Apnea is defined as an absence of breath for 10 seconds despite an effort to breathe. I think that last part is important to try to rule out a central disorder. And hypopnea is a 30% decrease in respiratory effort, respiratory airflow, and it also importantly must include at least a 4% DSAT. All right, so those are episodes of apnea and hypopnea, and then based on the amount of episodes of apnea and hypopnea that a patient experiences per hour, they give you your AHI score, your apnea hypopnea index. So your AHI score, if it's 5 or less, it's considered normal. 5 to 15 is, do I have that right? 1 second. So less than 5 is normal. 5 to 15 is mild. 15 to 30 is moderate. And more than 30 is severe. And let's just pause and just think about that for a second. So if someone scores 30, and remember this is a per hour index, essentially what that means is there's 30 episodes of apnea or hypopnea every hour, or almost 1 episode every 2 minutes. So it's fairly significant having a score of 30. And keep in mind, in this study actually, they didn't choose to operate on patients who just had a 30. In fact, they reserved MMA for only patients who had an AHI score of 100 or more. And that's even harder to fathom. If you're trying to think, what is 100 episodes every hour? That means they're having an episode of apnea almost 2 times per minute. And you have to be apneic for 10 seconds out of that minute. And if you're having 2 apneic episodes every minute, I mean, it's staggering. You're apneic for 10 seconds in order to meet the definition. And then I guess you breathe for 20 seconds, then you go apneic again for 10 seconds. So having 2 episodes per minute is a staggering and hard to fathom amount of apnea. And so specifically so they reserved MMA for only the severest of cases, only patients who had an AHI score above 100. They do mention that there's not a lot of studies that correlate having AHI scores in particular to increased health risks, but we know OSA is correlated to things. AHI is harder to pin down, and there's some good reason for this. There's a lot of confounding variables for sure. OSA, we know from the risk factors, it could be elder men, weight, neck circumference, obesity. So it's easy to imagine how there could be confounding variables when it comes to OSA and hypertension, diabetes, stroke, death, etc. Specifically, AHI has been harder to pin down, but it's fairly reasonable. I like how he phrases it here. In light of the SPART evidence, it's reasonable to make the assumption that an extremely high AHI score, and we're talking like 100, most likely carries an increased risk to the patient. I think that's a fair assumption. Okay. Then they talk about the treatment for OSA. So CPAP is the gold standard. It's non-surgical. The problem with CPAP is the compliance. So they mentioned between 30 and 80% of patients were found to be non-adherent because it's so uncomfortable. The device is cumbersome. There are problems with CPAP usage, air leak, skin irritation, and then also patients can report feeling claustrophobic. All right, so for all those reasons, CPAP is not well tolerated, and therefore, if they're interested in surgery, there is UPPP, which some ENTs offer, and then if they come to our department, something that we can offer is MMA, which is orthognathic surgery, where we advance both the maxilla and the mandible. Typically, it's about 1 centimeter. Although, again, not great studies that show that it needs to be a full centimeter, but the purpose is if you advance everything, you increase the posterior airway space. And on a lateral ceph, the posterior airway, this is just a good number to know, normal posterior airway space is about 11 millimeters. So it's intended, and here's a nice lateral ceph showing you. Here's a very small lateral ceph visualizing changes in the pharyngeal airway before and after. So you can see narrow, nice and wide. And so if you advance everything with orthognathic surgery, then you should increase that airway space. You should get less obstruction as the patient sleeps. You should get less apnea and hypopnea at night. All right, so this study, they're looking at the AHI, so they sent them for a sleep study before and afterwards. And then one other thing they also did was an Epworth sleepiness scale. That is a questionnaire that basically asks the patients, like, how likely are you to fall asleep during, and then they ask them a whole list of activities, like during a conversation with someone, or while reading a book, or watching TV, or sitting in a lecture, or, so various activities ranging from stimulating to not stimulating, and how likely are you to just randomly fall asleep during a long car ride where you're not doing anything versus maybe actively having a conversation with someone else. And then they score that. So there's an Epworth sleepiness scale plus the AHI, and then they also ask them patient satisfaction questionnaires, and then they did that both before and afterwards. All right, so that's basically the study. And like I said before, they restricted this to patients who only had an AHI over 100. They had 13 patients, and this is a staggering number, like I pointed out before. And let's look at some of the results. So 13 patients before surgery, all well above 100, 107, 133, 114, etc. On average, 117 pre-op. And then you'll look after surgery, an incredible reduction. So down to 1. This is 1 event per hour as opposed to 100 events per hour, right? And anything less than 5 is considered not OSA. Again, even the second patient is 38, so even he ended up severe, but still, look at the reduction. He was 133, and now he's back to 38. And look at the rest of the patients, 5, 1, 95. This patient number 5 is truly an outlier. He did not have such a huge improvement. He went from 117 down to 95, but everyone else, it was a huge reduction, 113 to 5, etc. So on average, they went down to 16. And remember, between 15 and 30 is moderate. So they went from severe, 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 because it doesn't even do it justice just to call it 1 severe, because anything more than 30, and that's a huge range, is severe, versus on average, they went down to 16. So a huge reduction in their AHI. Now let's look at the Epworth sleepiness scale. We said less than 5 is normal. So on average, they were 12, so they had daytime sleepiness. And then after the surgery, on average, down to 5. And I want to point out as well, the outlier number 5, the patient who did not have such a huge reduction in his AHI, he still had a significant reduction in his daytime sleepiness. Now maybe that was subjective or placebo, or for whatever reason, according to the patient, he felt less tired during the day. So maybe the reduction from 117 to 95, which may seem only a small, modest reduction, even maybe that was clinically effective. And then lastly, BMI, which probably was a coincidence. I was actually trying to think about this myself. You do notice a slight drop in the BMI, so 42 to 38, etc. Everyone had a slight drop overall from 38 to 37. I was thinking about that. Could that be related to after orthodontic surgery, patients are on a liquid diet for a prolonged time and they lose weight? Could that be the cause? Certainly. Could it be that, and could it be that a more positive hypothesis, maybe by improving their daytime somnolence, they had better eating habits and they lost weight naturally? The way to know would be, I guess, to follow them further and see if this BMI was just a temporary blip or if it was sustained. Either way, so that's basically the results. The discussion, he mentions everything we already talked about. Patient 5 was the outlier, but even he didn't have such a huge improvement. His EHS, his Epworth, was much better, and the patient denied having any daytime sleepiness. They talked about how before surgery they had everyone on CPAP and none of them could tolerate it, or 12 out of 13 couldn't tolerate it. So it just brings home the point that MMA is effective at reducing AHI and it should be considered. That's basically it for this study. I hope you guys enjoyed that. Let me know if you have any comments. I kind of love to hear from you guys. I appreciate you following along, and I'll see you guys at the next session.